Welcome, everybody. My name is Gregory Pfeiffer. I'm the Executive Director of the Institute of Current World Affairs, or ICWA as we call it. And it is an absolute delight to be here with you all. I'm grateful to the Elliott School for hosting us in this beautiful space. And I'm especially grateful to the Delta Phi Epsilon fraternity for partnering with us and enabling us to be here. Addiction, substance abuse, and public health policy are among the most pressing issues of our day. You don't need me to tell you that. And America's punitive approach to those suffering often makes it very hard to categorize what's being done in this country as harm reduction. The Institute of Current World Affairs fellow Rowland Robinson, who was an Andrew Weil fellow, spent 2 years conducting independent research across 3 countries with different progressive policies and approaches with the aim of drawing lessons for the handling of the opioid crisis and harm reduction in general in the US. He started in the Netherlands, and he spent time afterwards in 2 other countries that adopted similar progressive policies, Portugal and Brazil. He investigated pioneering policy as well as integrative healthcare approaches to problem substance abuse. He spent a lot of time on the streets with people who use drugs, as well as harm reduction workers. And he talked to experts and officials in the corridors of power. And he spent time in care facilities, and he attended international conferences speaking to leading experts during a very, very remarkable and in many ways difficult, but I also hope enjoyable fellowship. Before his fellowship, Rowland was a legislative assistant for U.S. Senator Angus King and an opioid response project manager for the state of Maine. And he's also the son of John Robinson, former fellow in Madagascar, who is here with us in the audience. Before we hear from Rowland, however, I'd like to say just a few words about the Institute of Current World Affairs. We send outstanding young professionals abroad and around the world on 2-year independent writing fellowships to acquire deep understanding about global societies, and they go on to become leading experts in international cultures and affairs. Another one of our former fellows, the pioneering expert on integrative medicine, Andrew Weil, is the sponsor of Rowland's fellowship. And he spent 4 years on his fellowship in Latin America and the United States in 1971 to 1975, studying drug use, medicinal plants, and alternative methods of treating disease. When he came home from his eye-opening travels, he urged a new revolution to break through medical establishment prejudices and corporate pharmaceutical barriers to the use of traditional medicines. He founded the Andrew Weil Center for Integrative Medicine at the University of Arizona, as well as the Weil Foundation, the Healthy Lifestyle Brands, and he was one of the co-founders of True Food Kitchen. Many of his views, which seemed radical at the time, are widely accepted today, and the Institute is proud to have helped been a part of that process. So all that is to say that Rowland is in very good company. And today he will speak for about 15 to 20 minutes and then join a distinguished panel whom I will introduce after Rowland speaks. And after the conversation, we will have a Q&A with you, the audience, and we will try to take some questions from those viewing over Zoom. And with that, I welcome Rowland.
Thank you, Greg. Thank you, ICWA. And thank you, Dr. Weil, for sending me on this wondrous adventure. And thank you to my friends and family, many of who are here today, for supporting me through that adventure. Like any good adventure, it started looking up at the stars, this time near Moosehead Lake in Maine. Just a few moments earlier, I'd shared a cigarette with a stranger, and he told me that his father had recently overdosed and died, and he's still dealing with that loss. I looked up the stars that night, and I asked, how will this end? And they twinkled back at me and asked the same question. The opioid crisis is much more than just those who use drugs. It impacts our families and impacts our communities. Through 2 years investigating pioneering drug policies in the Netherlands, Portugal, and Brazil, I can confidently say that the opioid crisis is solvable, that public health leads to public safety, and through compassionate policies, we can uphold individual dignity and ensure prosperous communities. And so, the Netherlands, land of tulips, windmills, and way too much rain. Walking around the central neighborhoods of Amsterdam, it was easy to think that it had always been this way. Tourists going in and out of shops, peaceful canals, and it was easy to think, oh, this is just a small, rich country where everything goes well and there is no poverty. But that is very far from the truth. For decades, for most of the 20th century, the streets of Amsterdam were filled with people openly using drugs and homeless on the street. So what changed? A key to that was looking at their famous windmills that pushed water out of the land and back into the sea and reclaimed farmland for hundreds and hundreds of years. This complex system of dikes had one fatal flaw, though. If any part of the dike broke, it would flood the entire community. And therefore, since the very beginning, the smallest farmer and the richest landowner had to come together at the table to ensure that the dikes held. And it is that type of polder model governance that led the Dutch communities to come together to solve the opioid crisis, where people who use drugs, as well as business leaders, as well as government officials, came together to figure out what policies would work best. Syringe exchange programs actually came from a person who was using drugs and was upset that other users were leaving needles in kids' playgrounds. Through this integrative approach, they let people get housing while they were still using drugs. They let people access workforce services. They let people access treatment, even if they were still using drugs. What does that mean? 40 years later, crime is at an all-time low. Tourism is up. People who use drugs are safe, and so are the people who walk down the street. From the Netherlands, I went to the rugged coast of Portugal. I started my trip in the Aljube Museum, a secret police prison under the dictatorship. There, I sat in one of the prison cells where they kept political dissidents, my elbows touching both sides of the cell. And as I sat down on the bed, I realized that it wasn't a bed, but just a slab of wood. And where I walked outside, when many people never had that chance, I saw on the other side of the street the Catholic Church, Lisbon's main cathedral, both powerful symbols of the authoritarian government that controlled Portugal for over 50 years and that left a long shadow even after the Carnation Revolution in 1974. So much so that when heroin arrived in Portugal in the 1980s, people who used drugs were called cockroaches. They were left to die, and Portugal became the scene of the largest open drug use neighborhood in all of Europe. 60% had HIV, 80% had hepatitis C, 90% had no access to treatment. It was only in the late 90s when people and voters decided that they had enough that the politicians decided to act. And the typical top-down model of the Portuguese society, it was in the government that brought together a group of experts and ended up doing almost exactly what the Netherlands had done, which is evidence-based treatment models, access to treatment, housing, workforce services, and social services, even when people were still using drugs. And what did that lead to? Portugal today is one of the safest countries in Europe and in the world. Everybody wants to move there. Tourism is booming. And again, people who use drugs are safe, and people who are walking down the street are safe. From one side of the Atlantic, I flew to the other. Brazil, land of sun, samba, and lovely chaos. On my first full day in Sao Paulo, where I started my fellowship there, I went to Cracolândia, which is the largest open drug use scene in the world. There, I was met by flashing lights, outreach workers from the Universal Healthcare Service doing their rounds, vendors willing to sell a piece of cake for anybody with 2 reais, while love motels abutted one-room churches. In this chaos, walking with my guide, we came across Braços Abertos, an NGO that for 3 years housed, employed, and kept care of people who had been living on the streets. It was a phenomenal success. 88% of those who were part of this program reduced their drug use by over 60%. 50% of them were reconnected with their family. 70% gained employment. But policy success is not enough. In a conservative country like Brazil, where people will greet you with, "I'm good, thanks to God. I will see you tomorrow if God wills it," policy and science was not enough. And so when the government changed, the program was ended. Brazil is famous for its violent police, which are many times more violent than here in the United States. What does that lead to? High crime rates and people protecting their houses with barbed wire. Is that the society that we hope to have here? What does it mean to solve the opioid crisis? Within the time of my talk today, 30 people across the United States will have overdosed. 2 of them will have died. Those are friends, fathers, family members in our communities. But this is a hopeful message because it is possible to change. Solving the opioid crisis does mean reducing the use of illicit drugs. It means reducing overdoses. It also means increasing safety for everybody who walks on the street. It means reuniting families. The White House says that the opioid crisis has cost the United States $1 trillion. But the real cost is in the empty chair at the Thanksgiving table, and it is at the uneaten hot dog at the 4th of July cookout. We can and must build coalitions. We can and must build coalitions that implement compassionate drug policies that both uphold dignity for all and strengthen our communities. Thank you, Ikwa. Thank you all.
Thank you so much, Roland, for that. And look forward to hearing more from all of our panelists. Before we get to the discussion, I would like to introduce our panelists while Roland is getting mic'd up as well. Amanda Lattimore, sitting in the middle, is a social epidemiologist and founder and CEO of On the Shoulders of Giants Consulting, a research and technical assistance firm advancing sustainable individual and community well-being. Previously, she was director of the American Institute for Research's Center for Addiction Research and Effective Solutions, AIR Cares. She teaches at Georgetown University and the Johns Hopkins Bloomberg School of Public Health. Joining us online is Maritza Perez Medina, who is a director of the Office of National Affairs at the Drug Policy Alliance here in Washington, where she leads the organization's federal legislative agenda and strategy to end the drug war. She led the national coalition that successfully pushed for the passage of the MORE Act in the U.S. House of Representatives in 2020 and 2022, marking the only times in history a congressional chamber voted to deschedule marijuana. She also serves as president of the Hispanic Bar Association of the District of Columbia. Also joining us remotely, Gordon Smith was appointed by Maine Governor Janet Mills as the state's Director of Opioid Response. Previously, he was the longtime executive vice president of the Maine Medical Association, where he began as general counsel in 1981. He was chairman of the American Society of State Medical Association Council, a nationwide group of attorneys representing medical associations, and he served on many other boards. And our moderator, sitting at the end of the table, John Heppen, is a policy advisor overseeing healthcare and public health policy for U.S. Senator Angus King. And he previously led policy work for U.S. Congresswoman Shiri Bustos on the House Appropriations Labor, Health and Human Services, and Education Subcommittee. After the panel discussion, John will field questions from you, the audience, and we will try, as I said, to include some questions from those viewing over Zoom. Please type your questions into the Q&A window. And I ask that you give your name and state your affiliation, and please stick to one brief question. Thank you, and now handing over to John.
Well, good morning. Good morning, everyone. Appreciate being here, and congratulations to Rowland for doing this incredible work, and appreciate the opportunity to be part of the conclusion of his journey. I think compared to the rest of the panel here, I would describe myself as more of a generalist. Obviously, we have some really incredible folks here this morning. But in terms of my work for Senator King, across the board, healthcare, which is very simple. There's not a lot of healthcare challenges that we're facing in our country today. I say that facetiously. So in terms of the work that I do for Senator King right now, a lot of it obviously is incredibly responsive to this administration, which is creating dozens of challenges, almost on a daily basis. And so a lot of my work is just trying to respond to the harms that this administration is creating. But what I would say in terms of kind of a positive element of the work that we do, Senator King and the work that I do leading his healthcare work is really focused on trying to change the narrative and change how we think about our healthcare ecosystem. A lot of the work that we do in healthcare, just based on how our system is set up, as many of you know, it's incredibly responsive. It's reactionary. It's based on episodes of care. It's based on crises where we have obviously this substance use disorder epidemic and other addiction crises that constrain resources and budgets and staff across policy and issue areas. And one of the challenges there inherently is just how we advocate for that in terms of resources. We pay for it on the back end. Just yesterday, Senator King reintroduced legislation called the Primary and Behavioral Healthcare Access Act. I have to look at that name just because it doesn't have one of those snazzy acronyms that Congress loves to have for most of their legislation. This bill would cover 3 annual primary care visits and 3 mental health and substance use disorder treatment visits at no cost. Obviously, the preventive health care mandate that's part of the Affordable Care Act provides care for certain services, but recognizing that just the actual fee itself for a doctor's visit can be an impediment to getting folks in the door, this bill would look to change that and reverse the structure. But I think one of the things that I really appreciate about that bill itself is that it kind of opens up the conversation of one of the challenges itself of our healthcare system. That bill is going to be costly, at least in terms of how the Congressional Budget Office would score that legislation. I don't have an official score, but I know that that's the case in and of itself, just based on our current system. And that's one of the challenges that Congress in and of itself faces on a bill by bill and issue by issue perspective. And in that vein, Senator King has legislation called the Preventive Health Savings Act that would look to change that and rectify that and look ahead to how we can have a more responsive system that actually spends money on the front end, recognizing that we can save lives, save costs, and look to save our healthcare system. The Preventive Health Savings Act it's very niche, and it's one of those bills that has a technical component to it. It's probably one of the least sexy elements to healthcare that I think I work on for Senator King, but it would change how CBO scores legislation. It would give CBO the ability to analyze legislation on a 30-year window. Right now, CBO scores bills on a 10-year window. So in terms of how we could look at legislation and score it, we would be able to actually really analyze and understand the full totality of how savings would actually be attributed to any bill that Congress looks at in the healthcare space. Right now, also, CBO can't incorporate preventive savings or preventive interventions into how they score legislation. You look at GLP-1s or weight loss drugs, all that CBO would be able to do is say Ozempic or something of that nature costs X amount of dollars. They wouldn't be able to incorporate how it actually would save lives and save the healthcare system in terms of addressing the obesity epidemic. And obviously, this has incredible ramifications for the addiction and substance use disorder space too. We know that in terms of getting folks access to care, treatment, or screening, those interventions and those public health elements cost money. And if we're able to quantify and say, yes, it's going to cost maybe $500 in terms of the office visit and the interventions, but on the back end it's going to save X amount of dollars. That's going to be revolutionary in terms of how we can look to better implement our healthcare system. So that's one of the things that I'm probably most excited about that I'm working on for Senator King. I think in this space I'd also be remiss in not mentioning that Senator King also works on wastewater infectious disease surveillance. That's mostly focused on the infectious disease space, but also has ramifications for how we surveil and monitor for substances of concern. This is obviously something that Europe does on a much more widespread basis. This administration is looking to potentially incorporate that into their work as well. But as we know, in terms of the challenges of over-policing, that there obviously is a really strong element of concern there in terms of how our law enforcement agencies would potentially use this resource. That's something that we're obviously monitoring for and are really concerned. You can see that there's a lot of things that Congress is working on, even though sometimes it appears that Congress is not the most active body. So I'll end there and just note that it's a pleasure to be here. Turn it over to Amanda.
Hi, everyone. Amanda Lattimore. I am a social epidemiologist, as was mentioned earlier, and I wanted to, in the 3 to 5 minutes that I have, just give a little bit of kind of foundational information, because I know a lot of what Rowland emphasized in his work is the connection between different social determinants, the importance of housing, specifically housing first policies. And so as a social epidemiologist, I teach at Georgetown and I'm also faculty at Hopkins. Having this framework is useful because it helps your brain organize all of these very complicated and interconnected factors. And one of the foundational models that I like to share is the a social ecological model. So if you think about at the highest level, you've got culture, your macro level factors, culture, norms, stigma, the way that people perceive drugs is an example of a macro level factor. And those things can alter the way that we interact with one another at institutions, with each other, And those interactions at the interpersonal level can restrict or facilitate access to resources. So material resources, social resources, and those things influence people at the individual level to behave differently. So behavioral factors, behavioral outcomes, psychosocial outcomes, and physiological outcomes. And so that transition connects things that are happening at a global level, at a macro level, to how we're interacting with each other, to how things ultimately play out for individuals and their health. So that social ecological model, if you tap in housing into that model, you can think about how our housing policies. So for folks who use drugs, housing can be very challenging to obtain. Let's say you've got the best of intentions. You are really trying to get well. You're trying to reduce your drug use or make your drug use safer. It's very difficult to do that with a system that is already penalizing you and calling you a criminal because of your drug use, thereby keeping you away from your ability to obtain housing. In some policies in some states, you've got lifetime look back periods on whether or not you're eligible for housing, which just means that they're going to look into, you might have an arrest, not even a full charge, arrest for drug-related crimes, and that might keep you from being able to get housing, access to benefits. And so those policies can influence a person's ability to maintain stability. And housing isn't just a roof, it is a place of, folks have identities attached to places and to homes. It's an ability for them to find stability, to get to their appointments. Just think about if when you travel or if you've ever had a renovation in your home, how much that disrupts your ability to just carry on and do the normal things that you need to do to feel well, to feel whole, to feel like you can go out there and tackle the challenges of the day. And so when you don't have that, or it's constantly disrupted, or it's just plain unhealthy, it's hard for you to get well, hard for you to make those healthy choices, hard for you to access those resources. And so it just trickles down, starting at the top. And how do people treat you when you don't have a home? How can you get access to a job if you don't have an address? How do you get an ID if you don't have? So it all is connected, and you can use that socio-ecological model to make those connections. And one of the reasons, and I hope you'll get to this, the Dutch model really pulls in all of those details. So in addition to housing, that's stability, you're also connected to employment and things that you can do to structure your day, because employment isn't just a paycheck. It also offers you structure in your day, pro-social networks that you can replace or incorporate healthier relationships to people, to others. It gives you a sense of identity that's not attached to drug use. So all of those things, again, it's a job. It trickles down to how people see themselves, that psychosocial piece, the physiological piece, the behavioral piece. So I love the work that you've been doing and how it really exemplifies well some of these socio-ecological connections. And I'm happy to talk more about that. I do want to also add to the conversation the importance of prevention, even going back further than just housing. But one of the ways that housing disrupts things for the next generation is there's research that shows when people lose their housing because of their drug use or alleged drug use, that often affects families tremendously. About 30% of the time when people have lost their homes because of drug use, a child has also lost a home. And that reinforces, pretty much ensures the transmission of challenges for the next generation. Because the biggest attributable risk for addiction is not genetics. It's not how many drugs are available around you. It's adverse childhood experiences. That means what happened, were you connected to someone who cared about you? Did you have a stable home? Did you have food to eat? And we do everything in this country to rip people away from that and basically feed the system so that addiction is pretty much guaranteed for the next generation. So we just really, it's the models that you'll be talking about today and that you have talked about in your dispatches that bring me a lot of hope for the future.
Thanks, Amanda. Why don't we turn it over to Maritza?
Hi, everyone. It's so great to be here today. And I also agree that the dispatches were such a wonderful thing to interrupt the day-to-day of what I do. So what do I do? I'm the director of the Drug Policy Alliance's Federal Affairs Office. So we're the office at DPA that is in charge of speaking with Congress and the administration on all of our drug policy priorities. If you're not familiar with the Drug Policy Alliance, we're the leading organization in the US that's working to end the war on drugs. We believe that drug policy should be grounded in health, human rights, and in equity. At the end of the day, we're a policy shop, so we really, so that's like our main focus, although we do organize and go into different states for different campaigns, that sort of thing. But I'm going to talk to you today about our work at the federal level because that's what I'm most familiar with. So at the federal level, I really like to describe our work as twofold. The first is that we work on criminal justice reform because unfortunately, that's how this country has historically treated drug issues or people who use drugs. And the other half of our work is around public health because ultimately we want to see drug policy grounded in public health. So on the criminal legal side, most of the work that we do there is related to the Controlled Substances Act, the CSA. If you're not familiar with the CSA is the regulatory framework for drug policy in the US. It was passed in 1970 by Congress, signed into law in 1971 by President Nixon. And a lot of people really see the signing of the CSA as the start of the war on drugs as we know it today. The CSA tried to align science and medicine with the drug policy. And I say try because, in my opinion, they really did fail at that. One prominent example is marijuana. You've probably read a lot about marijuana scheduling or rescheduling in the news lately. So since the CSA was signed into law, marijuana has been placed on Schedule 1 of the Controlled Substances Act. The CSA has 5 schedules, and Schedule 1 is supposed to be reserved for drugs that are most susceptible to abuse, that have no medical value, and have nothing to offer, right? Nothing to offer science or medicine and highly susceptible to abuse. But we know that marijuana is one instance where that's just not true. And in fact, the Trump administration's recent move to reschedule marijuana acknowledges that there is some medical value behind marijuana. In fact, one of the campaigns that we work on at the federal level is marijuana descheduling. As was said in the introduction as part of my biography, I have been working on that for years now in terms of trying to pass bills that would deschedule marijuana, completely remove it from the CSA, and also address the collateral consequences of drug use. What I like to remind people is that in order to get rid of the criminal penalties and the collateral consequences that follow those penalties, marijuana must be completely removed from the CSA. It must be descheduled. That's what we call descheduling. What the Trump administration is trying to do, he's finishing what Biden started, is rescheduling. Rescheduling just means that you're moving the drug from one number on the CSA to another. So in this instance, they're moving marijuana from Schedule 1 to Schedule 3. And Schedule 3 drugs are drugs that are supposed to have some medical value. Now, while that might be good for research, perhaps opening the door to more research on marijuana, and it will give tax breaks to marijuana companies, it won't do anything for the everyday person. It won't bring adult marijuana programs into compliance. It won't release anyone from prison, and it won't expunge any records. But this is why we're pushing bills in Congress that would do that. In the House, we have the MORE Act. As was said at the start of this presentation, the MORE Act has already passed the House twice. On the Senate side, we have a similar bill called the Cannabis Administration and Opportunity Act, the CAOA. And that bill will be reintroduced again very soon in this Congress. It has not passed that chamber yet, but each Congress we work to try to build more support for those bills. Both bills would do the same thing. They would deschedule marijuana, they would expunge records, they would resentence people who are in prison for marijuana offenses. They would protect non-citizens from deportation. due to marijuana activity. Something a lot of people don't know is that even if you're in complete compliance with state marijuana laws, immigration laws are very harsh in this country, and you could still face detention and deportation for any marijuana activity simply because marijuana remains on the CSA as a Schedule 1 drug. Actually, if marijuana remains anywhere on the CSA, it'll remain federally prohibited. This is another reason we're pushing for descheduling, not rescheduling, because that's the only way you can get rid of criminal prohibition. The bill would also address other collateral consequences like reinstate food stamps, and it would also reinvest money back into communities that have been most damaged by the war on drugs. And historically, we know that those are Black and Brown and low-income communities in the US. So it really is a comprehensive bill. Aside from marijuana, we also work on other drugs that Congress is attempting to put on the CSA. Unfortunately, when Congress hears about a new drug, their reaction tends to be, well, let's immediately criminalize it and put it on the CSA. We've seen that over and over again. Most notably, the most recent example was around fentanyl analogs. The HALT Fentanyl Act was finally signed into law by Trump when he came back into office, actually last summer. This was a bill that the Drug Policy Alliance fought really hard against because we know that scheduling drugs will not solve the problem. Scheduling drugs and throwing people who are addicted into prison has led us to where we are today. In fact, that's why we have the opioid crisis that we have today. We also know that when you criminalize one drug, another drug will replace it. This is called the iron law of prohibition. And we've seen this with fentanyl analogs. Because of the crackdown on fentanyl analogs, now we're seeing new synthetic opioids and synthetic drugs in the illicit market. Things like xylazine and nitazines. And by the way, Congress is also now trying to schedule those drugs on the Controlled Substances Act. And Congress does have that ability. So Congress can put drugs on the CSA, but the administration can do that too. And we prefer the administration route because when that route is followed, HHS has to do a scientific and medical evaluation on the drug. And they have to give that evaluation to the DEA, who then makes the ultimate decision, but at least there's some sort of science involved. Congress does not legislate using science. Often it's just, again, knee-jerk reactions. It's fear-mongering. And we've seen that time and time again with drug scheduling. So unfortunately, we're fighting those fights now. There are actively bills in Congress that would schedule xylazine, that would schedule nitazines, that would schedule things like 7-OH, or some people might know it as synthetic kratom. So these are, this is really concerning because we know at the end of the day, who is going to disproportionately suffer. And again, we know at the end of the day that it's not going to solve the drug crisis. In the criminal justice space, we also work on reentry campaigns. I know one of my colleagues here on the panel was talking about all sorts of collateral consequences that people are exposed to because of drug convictions. Two of those that are most prominent that you might not know about are people can still be denied food stamps for a drug conviction, and people can still be denied fair housing protections because of a drug conviction. In fact, people with drug convictions are the only group that a person can legally discriminate against under the Fair Housing Act. We're trying to get rid of those bars through a couple of bills. One bill is called the Fair Future Act. We're really hopeful that this bill will have some movement in this Congress, but this bill would get rid of what is called the Thurmond Amendment. The Thurmond Amendment was introduced by Strom Thurmond, notorious racist member of Congress, who inserted this into the Fair Housing Act to ensure that certain people couldn't qualify for fair housing protections. He was trying to target people of color, but ended up actually targeting people with drug convictions who, again, don't have access to fair housing protections. And we know that housing is such a critical component of a person having stability in their lives. The other bill that we're working on is called the Restore Act. This would ensure that people would no longer be denied SNAP benefits for drug convictions. And that bill is also making its way through Congress. And I'm happy to share actually that both bills have bipartisan support and bicameral support, which is extremely difficult, especially in this really politically charged environment. So that's really great news. And then the last bucket of our work, and a very important bucket of our work, again, is around the public health, like the public health portfolio really of drug policy. And what that's looked like for us under this Trump administration has been protecting federal funding. We've seen a huge loss in federal funding programs related to addiction, related to reentry supports, all the things that we know can put somebody on a path to a stable life. We've seen deep cuts at HHS to these programs. We've seen huge staff losses, and we've been accounting for that. In fact, if you visit the Drug Policy Alliance's website, and if you search for a federal funding tracker, you'll see that we've been keeping track of what the Trump administration and Congress have cut from HHS, which includes SAMHSA, NIDA. We've also kept track of DOJ programs that offered support for people who use drugs. Most folks in this room know that we've started to see the opioid overdose deaths go down. My fear is that we're going to reverse course if we don't have the support that people need. So a huge part of our fight has been educating Congress about those funding cuts and also demanding that in appropriations they protect these programs and that they fully fund these programs. So we've done a lot of work in appropriations to support that, and thankfully, so far, Congress has rejected a lot of the deepest budget cuts. I will say there are exceptions to that. For example, Medicaid, we know that they cut $1 billion in Medicaid, which is the biggest payer of addiction treatment in this country. But when it comes to other programs within NIDA, within SAMHSA, for example, we're keeping Congress on track. And we've also worked with Congress to prohibit them from restructuring HHS in the way that the Trump administration wants. Because if that were to happen, it would get rid of some programs that we like, and it would also, again, impact funding for overdose prevention programs and reentry and those sorts of things. So federal funding has been a big bucket of our work, but of course we support harm reduction, we support overdose prevention centers, syringe service programs, and we support access to treatment. We think that treatment should be available, that treatment should be affordable, that people should have access to treatment when they need it. But unfortunately, that's not the current the current framework that we have in this country. Treatment is very hard for people to access for a number of reasons. So we're always working to expand things like treatment, like medications for opioid use disorder, for example. But I will leave it there because I am past my time, but happy to talk more about what we do at DPA.
Thanks, Maritza. And last but not least, let's turn it over to Gordon.
Good morning, and thank you. It's a great honor and privilege to be on the panel. Thank you to the Institute and to George Washington University and everybody that's involved with today's program. We're very proud of Rowland. I'm going to be very brief so that we can get into questions, and I can get into some of the state policy, hopefully in response to some of the questions. So I'm just going to tell you a little story about my work with Rowland and how I came to know him when I took the position. And Governor Mills, I need to give her a lot of credit because she created this position when she was first elected in 2019, and she'll be termed out in December. So I'm the state's first director of opioid response, and I'm right in the governor's office. So I'm testifying on our package of bills in 2019. And at that time, Rowland had let's call it, Rowland, an entry-level position at the legislature as a committee clerk. And so I'm in that health committee quite a bit, and Rowland starts giving me books. And the first one was in the realm of Hungry Ghosts, which I bet that 90% of you have read. And so I said to myself, well, this is kind of unusual. This young man is something special and really has something to share with me. So we eventually got him out of the legislature, had him in my office, and we had him over at the Office of Behavioral Health, finally sent him down to Senator King's office. And I've read all his dispatches. And as all of you know who have read his reports, he's an excellent writer, very thoughtful, and of course he's been living all our dreams, right? Wouldn't any of us love to have 2 years to travel in these three very distinct and very interesting countries? So that's how that's the relationship I have with Rowland. We are also giving Rowland an opportunity to speak and to share his experiences at our governor's 8th and final summit, which in Bangor on July 16th, which attracts about 1,000 people. And it turns out that these summits have been very successful. So I'm going to kind of leave it at that. I'm the kind of the state policy person on the panel. I'm essentially a health lawyer. Um, I had the chance to be with the O'Neill Institute in February for their conference, and I know there's a lot of O'Neill Institute people in the audience, and I'm only sorry I couldn't be with you physically this morning. I'd love to be there with you, although I understand it's quite warm. Uh, but I think I'm going to leave it at that. So we have plenty of time for questions. My final thought just is that what I've learned in my 8 years of doing this work is it's very complicated. There's a lot of stigma. I'm kind of surprised we've been able to talk for 45 minutes today, and I don't think anybody's mentioned the word stigma and how it underlies almost everything that we all do. And that our whole program in Maine has been based upon the 4 pillars of prevention, harm reduction, treatment, and recovery support. And if I agree with Roland, I'm an optimist. I believe that we can solve this and we can make the situation so much better in this country. But we have to be successful in all those pillars. Every single one of those has its place and is really important. So I'm going to leave it at that. I really appreciate the honor to be part of the program this morning and look forward to the questions.
Well, thanks, Gordon. I think that actually is a great segue probably into my first question, which is about the stigma of addiction. And why don't we start with Roland? The stigma of addiction plays a powerful role in how policymakers respond to the addiction crisis. What role does stigma play against people who use drugs in the countries that you visited?
Yeah, thanks. And thank you. I didn't say thank you to the panel, so thank you all for being here. It's really an honor to be surrounded by you. And I think what a great question, and definitely would love to hear a little bit more from you, Gordon, because you've been with the stakeholders on the ground. What I learned out in the field is that I was really expecting, coming from the United States, I was expecting to go to particularly places like the Netherlands and Portugal and find a higher people, a people who were okay with other people using drugs and didn't have stigma at all. And that is not what I found. I think that one of the, in some ways, one of the good things is that you don't need to totally overcome stigma of people who use drugs in order to pass good policies for people who use drugs, right? And that's where I think we shouldn't shy away from the public safety debate, which a lot of people in this space argue, because public health, as I mentioned, is public safety. However, that doesn't mean that there shouldn't be targeted anti-stigma campaigns, particularly, for example, around doctors, who a lot of times hold some of the largest stigmas of the stakeholder community. We talked a lot about fair housing and how, at least in our laws, people shouldn't be discriminated against because they use drugs. But I'll give the simple example of cannabis. I think we think of the Netherlands as mostly as of Amsterdam, but that's kind of thinking of the United States as New York. It's not exactly the same thing. Once you get out of the city, people are very conservative. And one of the biggest examples of this that I saw was that there was a cannabis advocate, and he tried to do kind of a public awareness campaign. And so he reached out to a bunch of famous Dutch actors and Dutch politicians and kind of known people. And he said, "Hey, we know that you use drugs. I know that you use drugs. How about you just kind of do like a 30-second video for us?" And they said, "Oh no, I'm not going to get my name anywhere near that." But the Netherlands has had coffee shops which have let people use cannabis for close to 50 years, right? So I think when we have the stigma conversation, I think that it is important to have focused campaigns against it, but I also don't think that it should hamper us from being bold and optimistic about how we change policies at the larger level and not be afraid to kind of have that public safety debate. But happy to get other people's perspectives.
Well, I'll follow up quickly. I think that the stigma is getting reduced. Maine's a good pilot for a lot of this stuff. We got 1.4 million people, and everybody knows everybody else, and so many people have been affected. We were a very affected state, along with New Hampshire, West Virginia, Southern Ohio, and so many people have lost someone, if not in their own family, someone that they know, and so that has uh, been the tragedy that has led to more people understand that uh, that this affects families, it affects communities. It's just not one person who overdoses. Um, so I think the stigma is getting better. Having said that, we are in a pivotal place in this country where we are in danger of losing a lot of our momentum. I was with my colleagues by Zoom in New Hampshire, no, in Massachusetts and Connecticut this morning. We were discussing this, that we have to really work at this every single day to make sure that there isn't backsliding. I'll just give you one brief example that the likely leading candidate in one of the major parties in Maine for governor to replace Governor Mills says the first thing he'll do is eliminate the syringe programs, which we've had for 30 years. Um, so I just throw that out because it is this, we have to keep working at this very diligently every single day. We have created such barriers over the 50 years for people to get better. We've made it very difficult. We have an overdose review panel in Maine that does a deep dive into cases, it's statutory. We have protected discussion, and when we get done these deep dives, we're all left wondering, well, this is amazing that this young man at age 31 made it to age 31, had all the barriers erected, issues with trauma, child and family services, and then each way many times trying to get better. And it's so difficult, which is why the most amazing thing that I see is the millions of people in successful long-term recovery that have overcome these barriers, because they deserve our admiration and support.
Thanks, Gordon. I think that is a really good segue just to highlight something I think also that just about every panelist talked about here this morning, which is the siloed nature of so much of our response efforts, and obviously how breaking down those silos is key to changing and continuing the work of bringing down overdose deaths, and obviously continuing the work of fighting the addiction crisis. Rowland, one more question. Just talking about law enforcement and criminal justice systems, obviously are very different in the countries that you visited. Can you talk a little bit about how law enforcement played a role in the countries you visited, in the response efforts, and obviously thinking about it from the siloed perspective as well, how they worked with public health resources services?
For sure. Thanks, John. Law enforcement has to be at the table, and we shouldn't shy from having them at the table, right? And if you look at both the Netherlands model and the Portuguese model, law enforcement played an integral part in that response, and having them on board in any public health kind of policy strategy will ensure that policy succeeds, right? And I'll give the example of the Dutch model. All right, they did this amazing thing. They let people who use drugs access housing, access social services, access workforce, and 80 to 90% of folks were more than willing to kind of go and accept those services. But there was, maybe let's say 10% of folks who said, no, I'm very happy, on the street. I don't, I don't like all the rules that you have for me. I'm not going to take part in that program, right? Even with, this kind of like low threshold, the most low threshold and progressive model that I've come to encounter in my travels. Well, that's where, you do have to have some type of law enforcement play a role and say, we can either bring you to the housing and to the social services, or we can bring you to jail, right? And that's a part that's not talked about a lot when we look at the Netherlands and when we look at Portugal. For example, Portugal, I think there's a big focus on decriminalization. decriminalization is not depenalization, right? And so when somebody is caught with drugs or using drugs in public, the police do intervene. They do not allow open drug use in public, even though it is decriminalized. And that person with a police referral has to go to these drug consumption commission, drug commissions, drug use commissions, right? And as long as that person arrives in those drug use commissions, then they enter the public health sphere, right? And they talk to a psychologist and they get the resources and the information they need. But law enforcement is an integral part of making sure that they get there, right? So, I think law enforcement plays a huge role, but obviously, as Gordon knows, Maritza and everybody else on this panel, it's not always the easiest conversation. So, but we'd love to hear from any of you on that topic.
I think one thing to note in your examples is that folks were given the tools to respond to a behavioral health crisis. And when you show up to a behavioral health crisis, and the only tools that you have are handcuffs, then maybe you shouldn't be there because your tools are not appropriate for the situation. Now, if you show up and you have support, resources, a pathway to wellness that doesn't create more long-term consequences, and I say, great, all hands on deck. We need everyone's help to address this problem that affects all of us.
Yeah, I'll just jump in and say that, ultimately we think that, and I'll raise this because in the US, we're seeing this push from the Trump administration into a coercive treatment. In fact, there's been guidance that's been released that calls for pushing people who are homeless into treatment. We've seen this across states in the US, but we know that those are ineffective policies. We know that forced treatment is actually deadly and increases overdose risk. Forced treatment is also harmful in other ways when it doesn't kill. And it's really the rebranding of incarceration, which has failed us. The reason that we're in this crisis in the first place is because of these punitive tactics. So ultimately, again, it is about giving people the support that they need, finding the right size tools. But this also just reminds me of conversations I've had with even members of Congress around, let's say, Measure 110 in Oregon, which attempted to decriminalize drug possession. I think far too often people expect drug policy to be a panacea and to address other issues that are unaddressed in society, such as affordable housing. One lawmaker commented, well, after Measure 110, didn't we see more public drug use? What we're not talking about is the fact that housing in Oregon is prohibitive. It's extremely expensive. People, want to talk about these drug policies as solving other facets of society, but ultimately we really need to invest in social infrastructure to address drug use, including public drug use. We know that people use drugs across socioeconomic classes. It's the public drug use that a lot of people feel uncomfortable with for obvious reasons, right? Like we all want to feel safe in our communities, understandable. But people are using drugs publicly, they don't have anywhere to go. And this is why we support other solutions like syringe service programs, like overdose prevention centers. But I just wanted to name that because I think too often we expect drug policy to be this cure-all for other societal issues that lawmakers haven't addressed and don't want to address. I'll leave it at that. Happy to talk more about Oregon. Actually, the Drug Policy Alliance has a great resource on Oregon called What Really Happened. And I raise that because when Oregon comes up, we often see a lot of misinformation. And I just shared one example of that.
Yeah, no, Maritza, I think those are really great points. I think particularly, sorry, go ahead, Rowland.
Hey, Marissa, thanks for that. And I really agree with a lot of what everything that you said, and that forced treatment is, is proven time and time again. And Gordon and I have spoken about this, that usually ends up in worse outcomes. But one of the, I talked about, accessing housing even when you're still using drugs. But one of the other things that the Dutch did, which, I don't have a great name for it and they don't either, but it's kind of these, people call them drug consumption rooms, others call them, kind of daycare type centers. But it's where people who use drugs that would normally use drugs on the street and who may not have a safe home in order to use those drugs out of the public eye have these spaces in which they can, there's in the ones that I visited, you have a space where they can use the drugs. They have a place where they can hang out. They have a place where they can eat. They're called integrated drug consumption rooms. And they're in a supportive environment. And if they require social services, there's a social what's the word I'm looking for? Social worker there. Thank you. So there's a social worker there, and there are other resources, in that space, right? And so, so I just wanted to I think Maritza, you made some great points there, and just wanted to also clarify what I was talking about. Thank you.
Yeah, no, great point, Roland, as well. I think that could be a good segue to a question for Amanda, just around, you talked about adverse childhood experiences, or ACEs, and social determinants of health as well. I think it's something that is very much baked into what you've discussed and the work that you've done. Obviously, housing has been a really big piece as well of just some of the recent comments, but also I think overarchingly of Roland's experience. So just curious if you could talk a little bit about what else has stood out to you from Roland's experience in the various countries. Has been particularly from the ACEs and SDOH perspective.
Well, SDOH as in social determinants of health. And for those of you for whom this is not a term that just rolls off of your tongue on a regular basis, that just means the context in which you make your health-related choices. So, where you work, how you play, where you live, all of those things are social determinants of health. Some can be positive social determinants of health, some can be negative social determinants of health. And what I really appreciate about Rowland's work is how the social determinants aren't siloed. They are, your work has represented well how interconnected all of these things are. And often in our pursuit of, social determinants of health, solutions to the overdose challenges that we're facing, we operate in one agency because that's where the money sits, but really it involves all sorts of agencies, not just the housing department. You need to bring in connections between other human services and health services agencies. And so some of the work that I've done previously happened at the state level, and bringing all of these agencies together, asking both community and the professional, the folks who are creating the policies, the folks who are delivering the services, having everyone come together, put in their 2 cents. All the agencies are talking, and we asked, how do we address the problem of the overdose crisis, of addiction? And social determinants comes up over and over and over again. And not just one social determinant, but just generally wellness for people. It's not even about the drugs. It's about people being able to pursue a life where they feel like they've got agency and dignity. That's housing. That's being able to address your heart condition. It's a lot of things that have nothing to do with drugs. And therefore, the challenge is, how do we get agencies who are just thinking about housing or just thinking about treatment to talk? What spaces can we provide so that they can all say, oh yeah, housing is a problem for me, even though I'm the behavioral health authority, or a service provider is talking about the challenges of step downs or connections to social services. Having those conversations where you come together and connect the dots is really where it's at, and how some of the communities that you visited, they're solving that problem. They're connecting those dots. Because at the end of the day, everyone's doing the best they can. Everyone's doing the best they can in whatever sphere of influence that they have. Nobody's actively saying, well, I don't care. People who are working on this issue, they care about people surviving and living they can only do what they can do. So everyone's got to start talking.
I obviously have a lot to say, but I think you're absolutely right, and I appreciate you bringing that up. And because if we only look at this, and that was one of the big things that I discovered, we cannot just look at this as a simple healthcare matter and just as a personal healthcare matter. So the Netherlands, before they got into the whole low barrier housing and the drug consumption rooms that I described, they did evidence-based treatment. Everybody can access treatment whenever they want, wherever they want. It's a small country. They have a comprehensive healthcare service. But even after all of that, they still had people living in the street. They still had people using drugs openly. They still had problems because the point, a person is more than just their drug use, right? A person is somebody who has goals, who appreciates food, who enjoys dancing or music, right? And so giving them access to these, all of these things that we've talked about, housing, workforce, all these things, is a key part in ensuring that they can live the full lives that they deserve to lead. And if we just focus on the healthcare aspect, we are not going to solve this problem in a way that'll be satisfactory for them or for everybody else. And just in a way, one of my pieces was housing as healthcare. And one of the things that we saw even here in Maine is that if you give somebody housing, the chance of them overdosing is reduced. Gordon, you might remember this stat. It was at least 3 to 4 times less likely to overdose, right? So that is a healthcare outcome due to a non-healthcare policy, right? And so we need to be thinking about these as interconnected issues. Thank you.
Thanks, Roland. Why don't we open it up to questions from the audience? And I know that we have some folks who have microphones. And why don't we turn it over to our gentleman in the front?
Thanks so much, John and Roland and all our panelists. Fascinating discussion about something that is so important and about which most of the public knows very little. I would guess. Roland, you started out by citing the Dutch polder model, and the idea that because of the Dutch culture, very small country by territory, large population, people have to get along and have to cooperate in order to confront problems that affect everybody, and that you saw this as a motive, maybe the wrong word, but it was sort of a reason behind the Dutch tolerance of drug use, if not acceptance or condoning it. It's just a recognition that public safety, general prosperity, everybody's fate is tied toward policies that work, and this policy is, when it comes to drugs, it's harm reduction. So you spent 2 months, rather not 2 months, 6 months in the Netherlands, 6 months in Portugal, and a year in Brazil. I wonder, was there a moment when you were in Brazil that you had a sort of a similar moment that you saw a policy that works or that has the promise of working, and the explanation was there was something about the Brazilian culture, maybe different from the Dutch culture, but that enabled Brazilian policymakers to come to the same conclusion or a similar conclusion. And if I may, I'd like to ask a question of any of the other panelists who would like to address this. Was there something in one of Roland's dispatches that sort of that struck you as an example of something that would lead you to believe that the opioid crisis and our struggle with dealing with addiction and problem substance use can be solved? Is there something that sort of particularly struck you in what Roland encountered that you think this needs to be told to American policymakers and the public? Thank you.
Thanks, Greg. I'll start with the Netherlands and the community model, I think what is important to understand about, the Dutch, I'll tell you a little story. When I was walking down the sidewalk in Amsterdam, I would just be walking around trying to avoid the bikers who were trying to attack me by all sides. And I would look to my left or to my right, depending on what side of the street I was. And the Dutch architecture has these huge bay windows. And so I'd walk by, and one day I'd see a family having dinner. Another day I'd see, a woman, reading her book. Another time I'd see an old man looking straight back at me, right? And the point is that everything in the Netherlands is supposed to be out in the open, right? And so it's not, when I was living in, downtown Amsterdam, yes, there was a syringe service program, 5 blocks away. Yes, there was a drug consumption room 10 blocks away. There was also a row of red light prostitutes 3 blocks away. There was also a casino 2 blocks away, right? And the point is that in Dutch culture, they really believe in making everything out, having everything out in the open, right? That things need to be seen, people need to be seen doing them. That is the whole point behind coffee shops, right? They don't want people using cannabis in their rooms where nobody sees them. They want people using cannabis in a social space so that the do normal or act normal kind of social expectations keep everybody in line and doing the right thing. So I think the Dutch model is really unique in that it isn't just about drugs; it's just how they see vices more generally. As you know, I went to Brazil thinking that I would find something like that, but I really, in many ways, found the opposite. I really, obviously there's the Braços Abertos model in Sao Paulo, which worked really well, that tried to do that. But part of why it didn't work over the long term is because the Brazilians, while they are incredibly friendly and incredibly family oriented, they're also very individualist, and it's one of the most unequal countries in the world with South Africa. And so even though they have a universal healthcare system, which a lot of people don't realize, but they have a universal healthcare system, the fact, to Amanda's point, the fact that the socioeconomic disparities are so great means that the healthcare model just can't keep up with all the issues that folks had. So it was a fascinating work in our investigation in contrast, turns out. Thanks, Greg.
I think folks need to hear more about the housing first practices of the Dutch model. And I do not want to steal your thunder since it's your work. I'd love to hear you talk about that progression from yours to permanent housing to actually even the opportunity to own your space. So do you want to talk about that?
Yeah, for sure. So when the Dutch first started their program, it was, all right, first we're going to get you into these housing shelters, and then when you've done that for a little bit while, we'll get you into your own room within kind of a building. And if you do that for a couple of years and you don't have any problems, we can, you show that you're independent, then we're going to get you your own apartment, right? And those apartments were kind of spread out across the cities. And the idea wasn't to create, one neighborhood where these folks were. And again, it's kind of that do normal, that everything's out in the open, that if you're, going to get your groceries, you're going to be like the, 10 people closest to you at the grocery store, right? And then so they did that for, about a decade or so, and that worked quite well. But, then there's this housing first model that Amanda mentioned was, what happens if we take folks who are living on the street, who've been living on the street for a long time, and just immediately move them into their own apartment or their own housing? It worked, but it worked with caveats. And what I mean by that is that it's not just plucking somebody out of where they're living and plopping them somewhere else and assuming that they're going to be able to deal with all of those changes by themselves. Think of when you went to college, right? You had a support network, an institution that helped you make that big change from one part of your life to the other, right? And so when these folks, get, not picked off the street exactly, but when they move, from the street into a housing program, it does work, but it has to have those wraparound services with easy access to social workers and peers who can help them, who can help guide them into new habits and into society. But it is an incredibly useful model, and one, by the way, that started in the United States, that started in New York. So it's American made, but they just brought it to the natural conclusion while we haven't gone there yet.
There are U.S. studies that have shown time and time again the importance of that support, not just taking people into spaces and neighborhoods, but that support to help them maintain and keep the home, help integrate them into communities, that sort of thing.
A clean.
Thank you so much, Rowland, and everybody else on the panel. My name is John. I'm a former coworker and friend of Rowland and John's. My question for Rowland and anybody else, one of my frustrations in working on the Hill was that no matter how good the policy was, if you didn't have the politics, the votes to make it happen, it wasn't going anywhere. So what I've heard is that there are great policies out there that can really do a big part to address the opioid epidemic that we have in this country. Rowland, I'm curious if you saw anything in the political moments, the movements in Portugal and the Netherlands particularly, that you thought were transferable. Obviously, the cultural piece is one thing, but then what can we do from what you saw over there to make the politics work? And a lot of you on the panel work in politics, and I'm curious to hear your thoughts as well. Thank you.
Thanks, John, for that easy question. But there is an answer to that, and that's I'm trying to coin this like public health is public safety term. We'll see if it gains traction and all. But the whole point, and what I learned in the Netherlands, and it goes back to that stigma part, is that it's very hard to change culture around not wanting being okay with people using drugs, right? It's very hard to have that conversation. The only reason we have it with cannabis here in the United States, in my opinion, is because of Snoop Dogg and Martha Stewart and all these Hollywood folks that really made cannabis use kind of cool and so forth. And then the law changed. That's my perspective. You can disagree. That was and so that's where I think diving into that public safety debate, I think, is really important, and where we shouldn't have any problem going in, because when folks are housed, they're not on the streets when you're going home at night from the bar. When folks have a place to go during the day, so where they can use and get a full meal and hang out, they're not on the street harassing you or doing anything like that, right? And so I think we can have so I think that the safety component is part of that debate, right? And that's why I mentioned in my speech that crime went down when these policies were implemented, right? So this is so we are fighting crime through these public health policies, right? The second one goes to money, right? Because there's some people who are really focused on the money, right? And they're like, I don't want my taxpayer dollars to go to this person. Well, your taxpayer dollars are already going towards that person, right? When 911 is called, that's your taxpayer dollars that are going to have those emergency police go there, to have EMS go there. By the way, it's not just your taxpayer dollars. When that person is brought with EMS to the hospital and to the emergency room, your premiums go up because that person isn't paying, what it costs for their services, right? And so what has been shown, studying time and time again, is that housing first and these other services that we've talked about cost less than the incarcerated model that we currently have. And also, when we talk about EMS, we were just talking about this a little bit beforehand, right? When there's an overdose, the EMS go there, right? Well, maybe your uncle is having a heart attack at the same time, right? And maybe they're going to get there late because they had to deal with this overdose, right? And so when we are kind of reducing the number of overdose, bringing these people into safe spaces, EMS has can get to your uncle faster and save them. And then I think the third thing, to Gordon's point, is, and particularly here in the United States, where I think we're over 1% of the population of the U.S. population. We're 4.8 million people with opioid use disorder. So I think that math is right. Over 1% of the population using opioids. You probably know somebody, right? You probably know somebody who knows somebody, right? And so I think that's where we can learn from the LGBTQ campaigns of having an open conversation within families and seeing folks as people and kind of overturning that moralistic aspect to it. But I think it has to go on all fronts, and we shouldn't be afraid of having those discussions.
One thing that I might add, and I really like public health as public safety rolling out. I'm going to try to work on that and pushing that message on the Hill. But the message can be incredibly important. But I guess one thing that I kind of think about is how important it is to, for better or worse, I think sometimes change the message depending on the audience. I think about that a lot with respect to social determinants of health. My old boss, Congresswoman Bustos, was chair of the Social Determinants of Health Caucus. And, I think one of the things that always stuck out to me with that was depending on who we were talking with, for Democrats, we would talk more about, the equity lens, the healthcare lens. When we were talking about social determinants of health with Republicans, it was purely dollars. We were talking about, if you invest in this housing initiative or this transportation initiative, it's going to have an impact and a ramification on healthcare outcomes, but it's also going to save dollars down the road. And I think that that's something that, for better or worse, is just so critical. Is just thinking about what is going to break through. You might not get an equity discussion that is going to actually yield fruit when you talk about it with some of the more conservative members of Congress. But if you focus on the cost and how this is going to have a cost saver, it's something that I think is incredibly impactful and does break through.
Hi, my name is Joel Millman. I'm an ICWA trustee and former fellow, and now I can say I know two Robinsons from two different eras. One thing that strikes me in this discussion is that America and most of the world had a high tolerance for addiction, and it's a word we haven't used at all in this discussion when the addiction was to alcohol. And I'm wondering why those terrible addictions and destructive habits, where somehow the society had room for them and could manage them, which doesn't happen with narcotics. And why? What is it? Is it the diversity aspect? Is it the immigration aspect? I mean, I know there's an intertangled history with that, but once alcoholism was a known sickness but could be managed, it was somehow not punished as cruelly as narcotics addictions are now. So any comments anyone could make on what's changed and how we would change it back to a more humane attitude? What are you seeing in the world that gives you hope or gives you despair in that regard?
Well, as the social epidemiologist, it goes back to that framework I was talking about earlier, where you have these policies that have criminalized the possession of the substance. And those who possess that substance are now what? Criminals. And what do we do to criminals in society? We have sanctioned the extraction of those individuals from society, from the benefits of society. And that automatically creates a framing for people that this person doesn't deserve the same benefits as you and your neighbor because they have committed a crime. And when you use alcohol, you're not committing a crime. Therefore, it doesn't have that same negative halo over it. It's just the psychological process. That's a great question. I think that's what a lot of folks are trying to say, is that a drug is a drug is a drug. People will find a way. The real question is, why are so many people trying to take vacations, mental vacations, and not coming back? Not demonizing one drug over the other. The schedule does not actually reflect scientifically what is most harmful. I feel like the hook is coming out to tell me that I should stop talking. But I want to let you have the final word, but it is a matter of historically the United States and what makes money. It's the foundations of this country, tobacco and alcohol, kind of building the country's foundation, but also in the scheduling, not having any scientific backing whatsoever. And it's really been mostly economically driven from my perspective, but please. Yes.
So I have a dispatch on this, tip and swirl from the Porto region of Portugal. And I asked that question, right, which is, what is problematic substance use, right? And I think the kind of I went to the Lisbon Addiction Conference, and it was addiction is the continuance of behavior even after negative consequences. To Amanda's point, who gets to decide what is negative, and who gets to decide at one point it is so negative that it becomes a crime, right? And so if you were to drink 2 glasses of wine a day here in the United States, it might be considered, okay, something to watch out for. If you do it in Portugal, it's just another Tuesday, right? If you do it in Saudi Arabia, you might go to jail, right? Right. And so I think that cultural component is really real. And I think, talking about, class and race, alcohol is something that is preferred by the white upper class, for example, right? And so the negative behaviors around alcohol use, which is, kind of waking up groggy, acting out of line, that is deemed acceptable culturally by those people, and therefore it's accepted within the laws, right? And so, I think for me, that's the why. Like that's where it comes from. And another example from Portugal is that they're called drug commissions. They tried, which is, if you're caught in public, doing something bad with drugs, we're going to, bring you to these commissions. We're going to give you resources. We're going to give you information so that you improve your behavior. They tried to add alcohol to that list, and the Portuguese just wouldn't do it. The politicians wouldn't do it, right? Because they were just like, as long as it's alcohol, go at it. Don't worry. So I think the cultural piece and the class and race piece, I think, are really important aspects to answering that question.
Thanks, Rowland, and thanks to the audience for those fantastic questions. I know that we're just about at time. I guess maybe we'll have some concluding thoughts, or Greg, do we want to?
I just want to thank you all very much, and especially Maritza and Gordon online for being with us. And I just want to give you a big round of applause. Congratulations. Thank you. Really fascinating discussion. And I also want to thank the co-organizers of this event for their remarkable efforts, the Elliott School, and especially the Delta Phi Epsilon fraternity for all your work organizing this talk. And I'll just finish by saying that you can read Rowland's dispatches on our website, www.icwa.org. Thank you.